I'm here to talk about health risks and what we might anticipate in the future, as studies can allude to. As a medic in the insurance industry, I can certainly speak to risks, and as another role that I hold as a non-executive director in an NHS trust, so I have some informed opinions on healthcare as well. So I want to share with you some of my predictions based on the trends in the space, statistics to support my view, and I want to end with a few thoughts on what we can collectively work on to manage and mitigate these risks. So, firstly, I think employers in this room, you can all agree that there's a whole host of factors that you consider when you think about putting yourself forward as an employer of choice to make sure that your future fit workforce is there. But apart from some of the factors that I've listed on the right side of the slide, which you probably already are aware of, I want to flag some more variables to you that you might need to consider when you're looking at mitigating your people risk. And I'm going to dig a bit deeper into some of these points. But the first thing, you need to think about the fact that we have an aging population. I think that's already been picked up in the previous panel. And it's not just about a population that's getting older, but one where nearly 1 in 5 of our adult population are actually living with major illness. And this is not just a population statistic, and you kind of think, well, that's happening over there. There is a knock-on impact in that more working age people have long-term conditions than ever before. We also cannot walk past the fact that this disease burden is something that adds to the pressures that's already being faced by the health and care system. We know from NHS data that waiting lists are up, be they for elective surgery or cancer waiting times or A&E waiting. And this is again against the backdrop of an incredibly pressured workforce, which means that there is a significant proportion of the population's health need that is not being met. And some of the individuals who are on the waiting list and whose needs are not met will be working in your organizations. And then you get to the point of the actual treatment. Once you get to treatment in the healthcare system, not all of what we spend our money on is actually converted into positive health outcomes. And there remains an issue of overtreatment, low-value procedures, some of the things that we are collectively paying for. I know that the previous panelists kind of alluded to some of that as the role of the insurer to manage, and we are doing that. The last point in this is that while we're trying to grapple with all of these different issues, and I can see why you're all very busy, we still have the societal challenge of these widening health inequalities that we have an obligation and a duty to bridge. There is an 18-year healthy life expectancy gap between the most and least deprived parts in England. So let's look a little bit more deeper into the population health trend. While life expectancy has stalled somewhat, it is projected to increase from an average of 80.6 years in 2010 to 83.1 years in 2040. So that's on the graph on the left-hand side. So we have added some years to our life, but one could argue that we still predict that we're only likely to live till our 70s with no or some illness. So our health span is not projected to increase. And if you look at the top 10 high-impact conditions, so that's the graph on the right-hand side, you can see that there's a significant proportion of people who are likely to be living with chronic pain, diabetes, mental health conditions, and cancer. Again, there is a correlation between what was chatted about earlier on in the panel this morning. So now, some of these individuals that I was referring to in the population before will be part of your workforce. And in this report that was released by Health Foundation on the Working Age Health Challenge in November 2023, it was reported that almost 35% of the working age population have long-term health conditions, with nearly as many people in employment who report work-limiting conditions as they are inactive in the labour market. So that's looking at about 4 million people really we could be helping. So if you go a bit deeper into that specific report, you can see on the graph on the left that work-limiting health conditions have been increasing across all of the age groups. And intuitively, you might feel that the older you get, it is more likely that you're going to experience work-limiting health conditions. But I am going to challenge us on that thought, right? So hold that thought, we'll come back to it. What did catch my eye, though, and again, something that I've been picking up in these conversations we're having, is that the proportion of younger workers, the graph on the right, and this is a demographic of 16 to 34-year-olds, reporting work-limiting mental health conditions has nearly quadrupled. And so going back to the point of health inequalities, this report also highlights the fact that work-limiting health conditions are not experienced equally across all of the demographics. So here are some stats that are picked up from this report that you might find interesting. So 22% of working-age women report having a work-limiting condition, compared to 17% of men. And the prevalence of work-limiting health conditions is consistently higher among people with lower education attainment, especially those without a university degree or equivalent. And if you break it down based on ethnicity, it reveals that working-age people of Bangladeshi ethnicity are most likely to have a worse work-limiting condition, followed by those of white and Pakistani ethnicity. Now, look, I'm going to caveat this heavily by saying that the Health Foundation is planning to do some more work looking at the impact of intersectionality. But the only reason I'm really raising this is that there is a difference, and we need to highlight that these differences exist partly because of how the healthcare systems have historically been organized and whose health need we have been prioritizing so far. So, I just want us to kind of think about that and the role that we as employers have with trying to at least address some of these inequalities. Now, I'm going to drill a little bit deeper into two specific topics that we have had a lot of focus, especially because there's been an increase in claims volume and cost. So the first is mental health. It is estimated, and this is data from England, that 1 in 6 adults have experienced a common mental health disorder in the past week. Okay, and you can see from the map from NHS England that there's some regional variation for the prevalence. I suppose we can all hazard a guess as to what might be causing this in terms of impact and influence. And I think more worryingly, if you look at children's mental health, you can see there's an upward trajectory of mental health conditions. And again, the map's there to illustrate on the right that there's, again, regional variation with regards to children accessing mental health, learning disabilities, and autism services. So again, if you are an employer that has multiple sites, you might have a variation in terms of access to healthcare through this. I suppose the thing that really kind of made me sit and think is the fact that number of people accessing mental health services is 24% higher in 2022/23 compared to 2019-20. And I think we can safely say that mental health of our workforce is something that we have to address, especially when you link it back to the previous graph where we talked about the increasing prevalence of mental health conditions in younger workers. So the next topic is really driving increase in cost is cancer. According to Macmillan Cancer Support, we are likely to have 5.3 million people living with cancer in the UK by 2040. So to add to the increase in prevalence, I can share that also from our health insurance experience, oncology costs have increased by 34% from the period of 2018 to 2023, compared to, if you think about MSK conditions, which has only increased by 13%. So why this increase in cost? Apart from the fact that more people are living with cancer, we've also seen an explosion in advances in the world of oncology. Right, so we've got new active molecules that are entering the market. So you can see from 11 in 2012-2016 to 21 in 2017 to 21. We've also increased the duration of the treatment, so it is becoming more successful. So people are actually on this treatment for longer. We've got more high-cost cell therapies, and the dreaded CAR-T we think about, which is upwards of $1 million with regards to how much the funding cost. And then we've also increased in the usage of precision radiotherapy. Again, there's a cost attributable to that. So cancer care has really experienced remarkable progress and groundbreaking biomedical innovation, all fantastic things. And as a scientist, I feel incredibly energized by that. However, the counterpoint to these developments is that while we have these new treatments entering the market, we are still led by the promise that there is an increase in quantity and quality of life, and this hope does not always materialize into health outcomes. So oncology drugs are increasingly being approved through expedited pathways because we all want timely access to these treatments. And the studies I've listed on the right-hand side, it reveals that a large proportion of these oncology drugs, which are approved by the licensing bodies, offer minimal to no added benefit, especially those approved through expedited pathways. And compounding this is the fact that when these interventions are embedded in medical practice, it can take several years for them to be reassessed for effectiveness before you actually retire them from practice. And the median for this is about 9 years, and some medical kind of interventions is taken up to 50 years for them to get off the kind of medical clinical pathways. So in a resource-limited state that we're in, we really need to sharpen up on how we respond to high cost and minimal benefit treatment. So I've kind of looked at some of the macro trends that were converging, but I'm mindful that all I've been focusing on is the illness side of the health spectrum, and it feels that this seems to be a bit outside our locus of control, apart from the fact that obviously we are paying for this, right? But if I can entice you to zoom out to the bigger picture and then ask ourselves whether it is really a foregone conclusion that we will need to manage this disease burden that I have shared with you. So if you think about it from a first principles approach on what are the building blocks that ladder up to the health state, you'll find that factors such as employment, work and education, housing all play a contributing role to an individual's health. The latest view is to actually add information as another social determinant of health. So shout out to all the internal comms people, you are shaping the health of your workforce. So health happens at home, on the high street, in the workplace, and not just in hospitals. And to this end, NHS has actually recognised that businesses have a role to play through workplace wellbeing. So with this permission to play, it is important that we look beyond the traditional benefit suite to challenge ourselves to deliver effective, efficient, equitable, and enduring health outcomes for our people. And as employers, I think we all have a duty of care to improve the population health of our people. And I just want to end my segment by acknowledging that, even though it might feel a bit scary, I feel that we are indeed privileged to be at this inflection point, because the decisions that we make today and how we design our society has lasting impacts on our future. And it is for this future that I believe that we need to double down on value. And here are some areas where I think we need to spend our collective minds working on. We all know that prevention is better than cure, and there is sufficient evidence to support this stance, especially in oncology. According to Cancer Research UK, 4 in 10 cancers are linked to modifiable lifestyle factors. So this is an area worth investing in. Better access to early detection and diagnosis is something we all know about, but are we designing our benefits based on equity of access? So we've got all these products, as you've mentioned it, but, are people accessing them? Who is not accessing the existing benefits, and how do we open them up for access? I've already touched on this, that evidence is critical to evaluate benefits of treatment. We need better quality data. We need to actually ask those questions in terms of interventions that we fund as to whether it actually increases quality and quantity of life. And when we think of value, I think we need to think beyond that technical value and include questions like, what actually matters to this individual and to the wider population? And what does this mean for how do we distribute our resources? And again, with my sustainability hat on, how can we start thinking about the health cost from a planetary and population perspective? What is the carbon cost of some of the benefits that we put forward? And as we start thinking bigger, we need to think of the entire health system beyond all of us in this room and the wider healthcare ecosystem. We need to collaborate with people who are, out there in the community. So as a big organization, how can you show up as an anchor organization in the communities that we are part of? And lastly, we need innovation, but not the ones that we're usually swayed by, right? Like another app or a shiny toy or a fancy machine. These innovations that we want to implement should not be ones that widen inequalities, but actually innovation that addresses the gap that currently exists. So I feel that the volume and velocity of the trajectory of health risk that I've put forward to you might feel a little bit overwhelming, especially the initial few graphs, but we are rapidly approaching a point where we need to act on this emerging health risk. And I want to end with my favorite surgical hero, Atul Gawande's quote, "Better is possible, but it takes for all of us in this room to make intentional decisions, or at least be willing to try to do so."